34 years old. I was diagnosed with triple negative, stage one triple negative breast cancer, January 2020. I am also a BRCA2 gene mutation carrier. And where I am right now, I just finished up chemotherapy. I actually just had my port removed day before yesterday. So I'm still kind of fresh in the journey. And my position right now with advocacy is just grabbing my sister's hands because I need them to hold my hand too right now. So that's where I am. Look forward to the conversation.
Thank you, Aliya. Patricia Fox.
Good morning, everyone. My name is Patricia Fox, and I am a lead angel with Tigerlily. A beauty expert, and I am passionate about advocacy. I was diagnosed in 2013 at 26, and I truly believe in assisting other people with being their best advocates. And it doesn't have to be abrasive, but it is to gain clarity, be aware of any inaccuracies, whether it's your billing or your reports, and to just ensure that we're getting the best care and all advantages possible. And so that is, in essence, who I am and what I bring.
Thank you. And last but not least, Dr. Tisha Felder.
Good morning, everybody. As Shonda said, I'm an assistant professor at the University of South Carolina, and I will continue to say that I'm honored to be a part of this conversation and hope that whatever I'm able to present this morning just sets the stage to hear these amazing stories and how we can try to impact the care that particularly that Black women receive in cancer.
Thank you, Dr. Felder. And I just wanted to, before I go into the introduction and just give a little recap on how we ended up at Telepathy, I just wanted to know if anyone, if this is your first time attending, if you could just raise your hand or in the comments or, okay, I just want to get an idea as well so that I can know how much to go into. Okay, so we do have some newcomers. We're so delighted to have you all here. Okay, let me reshare my screen. Uh-oh. Okay. All right. Move you guys to the side. Okay, so all right, so the five agreements on how to be in conversation. Please monitor your airtime, speak your truth. Please speak from your own experience, lead with curiosity and not judgment, and keep the space safe. So our reason for it being here really started, so Tigerlily Foundation was started about 14 years ago by our founder, Mayma Carmo, who at the time was diagnosed with breast cancer at the age of 31. And so our work has always, included diversity and inclusion and worked in that space. We really moved forward even more so with that in March of 2019 in collaboration with the IRIS Collaborative. And so we've reached over 200 million people from rural to grassroots and global communities through the following disparities initiatives. We launched a Black Women and at our Young Women's NBC Listening Summit, and in March of 2019. In November of 2019, we had a Young Women's NBC Disparities Alliance on Capitol Hill in partnership with grassroots, state and local, national and global health partners and policymakers at our 7th annual Young Women's Breast Health Day on the Hill. In December of 2019, we held a historic event at the largest convening of women of color at the largest global breast cancer scientific gathering, SABCS. And we were able to host a fireside chat that brought the voices of young Black women to SABCS. And we have partnered with GRASP on that, bringing together a record number of Black women together with scientists for poster sessions. In January 2020, we assembled a cohort of 20 Black women representing cities in which Black women have the highest mortality rates for a year-long intensive and immersive program that addresses systemic barriers, social determinants of health, social competencies, mistrust, and mobilizes these young Black women for outreach and impact in their communities where they live and work. So this, these are our 20 areas of impact. As you can see, the different cities and our phenomenal inaugural class of MBC Angel Advocates. So in May 2020, we had our second scientific immersion activation at ASCO Confab, and where we brought together scientific communities and Black women for a powerful and culturally focused virtual learning experience. In June 2020, we activated we launched the Inclusion Pledge on change.org, and we have over 50 global partners and over 11,000 signatures. The pledge is really to bring about systemic change at every level of our healthcare system as it affects Black women. We've had Pfizer, Merck, Sanofi, a lot of large pharmaceutical companies that have signed the pledge and are working towards this, and we're holding them accountable in this space. Which brings us to No More Disparities and Pull Up a Seat. So No More Disparities, which occurred 2 weeks ago, well, I'd say 3 weeks ago, we had a conversation which was facilitated for and by Black women to create a safe space to have honest conversations with Black physicians, patients, and medical clinicians. We have these conversations on a monthly basis, and then typically 2 weeks after, we have the second one. So for instance, we're going to have one November 13th. The following one will be November 20th, and which is where you guys are now. We're at Pull Up a Seat, which is where we bring together our Black doctor and Black patient experts to amplify the voices of Black women through candid conversations. And we're going to do that through breakout groups. Really excited for you all to experience this. So I will now turn it over to Julia, who will share about GRASP.
Hi, everyone. It's really nice to be here this morning talking to you. So this is really about the women that are going to be leading this discussion. First, Dr. Felder, and then the 4 patient experts. We brought you can leave that slide up, Shonda. We brought a model that we used at scientific conferences. So GRASP stands for, oh my God, I just blanked. Christine, are you on? Guiding researchers and advocates to scientific partnerships. Sorry.
I am on, and that is correct. It's October. It's been a long month. It's okay.
Okay. And what it is connecting patients with the people presenting science on cancer. So we launched this program in San Antonio last year. It started with a very informal conversation that Christine was having with a scientist that we know, and they were walking through the poster sessions and realized that patients and scientists are experts in their own space and that they have so much to learn from each other. So patients are experts in living with cancer, and scientists are experts in the science of cancer, and doctors or nurse practitioners and other clinicians may be experts in treating the patient that has cancer. So we are elevating the patient expertise, and that's in the GRASP format was really planned around the science and scientific conferences and bringing patients to those spaces. What we did with pull-ups is we brought this idea together with Tigerlily and the experience that MEMA has in elevating the expertise of patients, in this case, the Black women living with cancer. And they have a unique experience where they have cancer and they are Black and they experience the healthcare system being who they are. So we wanted to put that at the center of these discussions and have healthcare providers participate in very intimate, honest conversations that dive into the hard stuff and talk about the very vulnerable conversation of race and how Black women are treated and how the disparities start on an anecdotal level of the patient experience. And we'll also hear from Dr. Felder how an academic thinks about that and what the data presents. So you have at the bottom a couple of pictures of Mayma when she was diagnosed with triple negative breast cancer 14 years ago. And as well educated as her doctors were, and she has connections with researchers, but that experience of actually being the person living with cancer while being a Black woman, she has that, and her story has to be elevated for that reason. And you also see a few pictures of the first GRASP that we did at the symposium. As we said, we partnered with Tigerlily and bringing a lot of the patients that were already at SABCS for the Angel event and the fireside chat, and we kept them there, and we had them attend these discussions with scientists so that scientists are interacting with a diverse set of patients that are living with cancer or have had an experience with cancer. So today, the patients are the experts. We really hope that people are going to show their vulnerability, and we are all here to learn. We encourage you in the small groups to keep your camera on. So if you want to keep it off right now while Dr. Felder's talking, that's fine. But once we move you to small groups, this is a very small group where the conversation is going to get very personal. We want to allow people to look into each other's eyes or cameras and have those connections. And we will have, we have white allies that are listening in and that will be in the groups. They're just going to be taking notes. We are not recording any of this, so they're going to be taking notes without any attribution. So please be very honest, and it is a safe space. But we want to be able to grab nuggets and thoughts that we can then put together in a document that will be shared widely. So these sessions, in order to be very honest and intimate, they have to be small. But for us to affect many people in the future, we are making this whole thing into a document that will really teach healthcare providers how Black women want to be treated when they have a cancer experience. So I hope you have a good time. Thank you for being here. Thank you to all the patient experts. I'm humbled to participate and very eager to see Dr. Felder present. Thank you.
Thank you, Julia. Thank you for sharing that. And now we're going to have, we're pleased to present Dr. Trisha Felder, who again has already introduced herself, and she will share some nuggets with us. So I'm going to stop my screen share so that Dr. Felder can share her slides.
All right, good morning. Can everybody see my screen? Okay, so today we're going to be talking about cancer while Black, how trauma, fear, generational pain, and mistrust impact breast cancer. And we had, as Shonda had mentioned earlier, we had a conversation a few weeks ago, and I appreciated hearing the stories of the amazing patient experts that are in this group with me. And so I listened to them, and I'm hoping that I'm able to communicate some of the things that they shared during that time and connect it with some data, and I think in some ways of how these concepts make sense to me and how they might actually show up in the form of breast cancer. So I'm going to talk about the context of having breast cancer while Black, how what we carry as Black women impacts our health, and put that within the context of breast cancer, and end it with, what does this all mean? So cancer while Black. I am going to share a video, a very quick video clip, and then I'm going to come back and we're going to move forward with the presentation. So just a moment. I'm sorry, guys, hold tight. Let me get to the page I'm looking for.
Mobility is essential to freedom.
It's difficult to overstate the importance of the road and the car in American life.
What it means to be American is to take to the road.
To control your own destiny.
Discovery, freedom.
Could I see some ID, please?
The notion of driving while Black reminds us that that's not available to all Americans.
Living while Black, sleeping while Black, eating while Black, moving while Black. That goes all the way back to day one.
The power to choose, to be able to move freely in space. We live in a country where it's never been everybody's right.
If you're an African American and you can afford a car, it provides a powerful alternative.
What the automobile allows is personal freedom. I think the automobile allows us to understand the way that African Americans have moved forward in this country and the way that African Americans have been pushed back.
For African Americans, trips across country are not adventures. They can often be trials.
With a car full of your family whom you love, and your wife is saying, we got to stop for the night. And what do?
So that's where the Green Book was indispensable, to give you some way to find a place where you could get some rest, get something to eat without being violated.
Once they were inside this building, nobody was going to worry them.
People are not going to let themselves be paved over. They will insist that their voices are heard.
This officer is unlocking my car.
There are still so many dangers. African Americans are feeling a similar fear as their grandparents felt.
That's how y'all treat Black people, huh?
We have to engage history with a kind of brutal honesty.
And until we get to a place in which we actually are trying to live up to life, liberty, and pursuit of happiness for every human being who is in our society, then we're not there yet.
Let's see. So I hope that you guys, I hope that worked well, that you could hear that. But I wanted to show that because I feel like it is a metaphor for what it really means to be Black. And they're talking about it within the context of driving. But we know that there's a shared experience of many African Americans in this country. And so I just wanted to point out to those quotes to me that apply, I think, to what we're talking about today, is that you know, living while Black, all of these things that we do, we're still carrying this historical trauma that we have experienced, whether we have articulated it throughout our families or not. And then also that there's so many dangers that we continue to feel similar fears, even as our ancestors have felt. So that was kind of, again, just a metaphor for, I think, the experience of the historical trauma that we have had in this country. But I also think that when you look at where we are now, in particular in 2020, there seems to be a modern day reckoning around racism and police brutality. All of these things are kind of coming to a head right now during this time. And so when all these things are happening following the murder of George Floyd, there were so many statements and commitments made by different organizations to deal with racism, to call it out, to talk about the fact that we want to end it, we're going to dismantle it. And so I think that we're kind of at a very unique time right now where I think all eyes are on these issues, and we need to use this time to build and to move forward and to raise the voices of Black women now more than ever. So within this context of where we are right now, I just wanted to present a little bit of data about kind of where the general population is around how they feel about race in America. And what I think is really interesting with all the different examples that I'm going to show you is that there are really stark differences in how Black people feel about their everyday reality versus many white Americans. And so you can see where Blacks are more likely to feel that discrimination is a major obstacle in our everyday lives. You can see between Blacks and whites, there's a 30% difference in that perception. That Blacks are more likely than other groups to see our race as central to our identity. And I can't speak for all the Black women on this call, but I know for me, I feel like everything in my life gets filtered first by the fact that I'm a Black woman. So even as a scientist, I'm a Black female scientist. Everything comes through that first. And that whites and Blacks differ widely on how Blacks are treated. And here I just wanted to highlight, so you can look across all of these different areas, there's big differences, but in particular, I wanted to highlight that when it comes to seeking medical treatment, almost 60% of Blacks feel that they're treated somewhere less fairly than whites versus only 26% of whites. So again, I shared this to just show this broader context of where we are as Black women, but then also within how others view their experience. And you can see how I think this makes a lot of sense around why we see such stark differences in how we're treated, particularly in the medical and healthcare settings, because there is such a stark difference in our realities. So how does this impact breast cancer? So I want to start this by stating that it wasn't always this way. And when I'm saying that, we talk about that 40% difference in mortality between Black and white women. And I just want to remind us that it wasn't always that gap. Back in the early 80s, the mortality rates between Blacks and whites were pretty similar. And it wasn't until the push for mammography and that there were a lot of cancer advances going on in treatment that we started to see this gap. And so I want to put that just in the back of your mind, because I think when we talk about addressing disparities, we have to remember that a lot of what's driven the disparities is really the unequal treatment of Black women. There are genetic differences here and there, but those are very few of the breast cancers that get diagnosed. But primarily, what's driving it is that we're not giving Black women the same care, and they're not having the same level of access to the same care as their counterparts. So I'm a behavioral scientist, so I'm always trying to think of how these things fit together. And I reflected a long time on this topic to see how in the world do I think these concepts fit together. And so, of course, when we talk about racial disparities and we talk about Black women with breast cancer, we have to come from the mindset that a lot of what's driving this, again, to my earlier statement about things changing, is that there are just really these big structural issues. And those structural issues, a lot of the origin of that is racism. I think we spend a lot of time talking about what's racist, what's not racist, who's racist, and really a lot of what we're experiencing is at that higher structural level. So from my perspective, we have so racism, again, is just a key part of life. I think we all would know and accept that. And having those experiences of fear and trauma based on the things that we had saw in the video, just those things alone, we pass that down. And then that will impact kind of how we see the world. So who we trust, how we trust. And I think we carry all of that, and it impacts how we process things psychologically, but also, and I'll talk a little bit more about this in my presentation, but how that can actually get under our skin and cause biological changes. And then of course, that can impact our broader health outcomes, which includes breast cancer. So our generations teach us about our identity and who we can trust. And I like this quote because it talks about these ties between children and their ancestors. And having those connections tell us who we are, who can we trust, who are our enemies, what ties me to my family, and most importantly, of these ties, which do I reject and which do I keep? So when we're looking at this issue of mistrust, a lot of times we're talking about mistrust, we're kind of coming from the angle that the mistrust belongs to the patient, but we're not necessarily given the context of where that came from. And so this review that was published just this year, they did a review of a lot of articles that focused on breast cancer. And the takeaways from that is that in general, mistrust is associated with lower rates of treatment and follow-up, particularly in Black women. And then within, I showed here, the slide is just kind of a synopsis of the qualitative work, but you can see that when across all of these different racial ethnic groups, and not just African-American women, but American Indian women and Latino women, Hmong men and women, that there's mistrust is present. And that a lot of the mistrust stems from historical trauma. So again, thinking about the way this is flowing, at least in my mind, is that, again, we've got these issues and we're carrying this across generations. A lot of the conversation that we had in our earlier group a few weeks ago was talking about, family history and having these conversations. And sometimes we're not sharing this information, but I think a lot of that is also just steeped in the generational pain of constantly trying to survive as African Americans. So that sometimes, so there's this concept of allostatic load that basically says that these heavy stressors that we're carrying, including things like racism and discrimination, can actually impact us at the biological level. And so the studies have shown that higher levels of allostatic load, and these measures are a mix of an index of measures. So it's like blood pressures and A1Cs, like different measures of that together, but it shows that there's an increased risk of all-cause and cancer-specific mortality among Blacks and whites. Again, just this year, another paper has just come out, and this is probably one of the first that focused on breast cancer, and it focuses on Black women. But what is astonishing is that this study found that that these pre-diagnostic allostatic loads, so these measures of allostatic load before diagnosis, actually predicted more aggressive cancer, breast cancer tumors in Black women. And this was a cohort of this study just focused on Black women. And so again, I think that just shows you that from that hypothesis, sorry, I'm trying to keep myself on time, y'all.
You can keep going.
Okay, I have my timer go off. But basically what this is showing us is that the stressors that are being carried and that are chronic, and again, things like racism and discrimination again, can get under the skin and actually impact our bodies biologically. So this other study was about racial discrimination and superwoman schema. And I'm sure many of you have heard of it. And if you don't know all the details of it, I'm sure you've been called a superwoman at some point or a strong Black woman at some point. And so that's where this concept, that's what this concept is really about. But they were looking at whether or not there's a relationship basically between discrimination, superwoman schema, and allostatic load. And what's interesting is that I think sometimes people see superwoman schema as something that might be perceived as negative, but there's very much, I think, a lot of strength in it that we need to really exploit in terms of using Black women's strengths to address our own health. And so what this study showed was that these particular elements, so there's different elements, these 5 elements that are here, but the element of strength and emotional suppression was actually protective against any negative impact of the allostatic load or that chronic stress. And then also on the other side, the motivation to succeed and obligation to help others actually made it, I guess the effects intensified that discrimination had on allostatic load. And here I'm just showing a snapshot of a study that my team did where we were looking at, we interviewed African-American women with breast cancer. And just to show here, we didn't use a framework of superwoman schema, but it's interesting how even our themes fit. So one of our themes was showing that for Black women, they felt a need to protect others, even while they were going through cancer. And so they kept some information to themselves. Sometimes they felt like they had to be strong for others. And so again, this just that whole concept of superwoman schema, again, which is not necessarily a bad thing, but I think it is somewhat of a common experience for many Black women. And it's something that I think providers need to be aware of in trying to again, provide the best care, but to really kind of understand the experiences that Black women are bringing to the healthcare environment. So what does this all mean? So a couple of take homes from this, I would say, is that with mistrust, I think we're asking the wrong question. We're always saying, well, why do Black patients mistrust the medical care system? Where I think we should be asking, why should Black patients trust the medical system? As we know, you know, there's a history of Black people being mistreated by the healthcare system, the medical system, the research establishment. And so, so I think in order for us to move forward, I think we have to come from the standpoint of having a shared conversation that acknowledges the realities that Black people have experienced. And also, in my opinion, I don't think for most Black families, you know, we're sitting down with each other and we're saying, hey, we don't participate in research. Hey, we don't go to the doctor. I don't think we do that. I think what we do is we just share our experience. We see whether or not people do these things, or we hear statements about the fact that Black people don't do this or Black people don't do that. So I don't think it's so much that we're teaching them about Tuskegee openly, where some families might, but I think there's just a knowing that not really sure if we can trust this, trust that. Again, going back to that statement about the ancestors and us learning from them who we can trust. And I think history has shown us that we should be a little suspicious. A take home here is understanding generational trauma and pain. I feel like this is something that both patients, but also providers need to understand. I love from our conversation previously, Patricia said that there's a pathology of not just DNA, but a pathology of generational experience. And so just to drive home that, yes, you're looking at a pathology report, you're seeing certain things with the tumor behaviors, but at the same time, recognize that this patient is also coming in with a generational experience that it is important for you to connect with in order to make sure they're getting the care that is needed. And lastly, that strong Black women still need equitable breast cancer care. Something that Aliya said, again, in our previous conversation was that her provider was saying, well, this is the standard of care and this is what this is what the book says, this is what protocol is. And she stated that I'm not a by the book person. And that just jumped out to me about the fact that personalized care is not just about the therapy, but it's also about the patient's lived experience. And so we really need to make sure that, I think there are stereotypes about Black women, and, that Black women are strong and that they're going to figure it out and they're going to fight. And sometimes, maybe even unbeknownst to themselves, you're not providing every issue, you're not providing all the resources, you're not asking all the questions that are needed to really get down to what she might need. I think it's important and critical to listen and to address any unique concerns or stressors. A constant theme that I've heard from survivors is that they said this to their doctors and their doctors were like, hadn't heard that. I'm not sure, that hasn't been reported. But that doesn't mean that that reality is not real for them. And so I think we have to make sure that we're listening and documenting those experiences of these survivors. And lastly, that we need more patient survivor resources that target Black women. And so here, I'm not going to read all of this on here, but I think that there's key things that needs to be done in provider education, leadership, and research. And in general, I love this quote from one of my colleagues' papers that says Black women must be prioritized. And I think that's really what the issue is that Black women have not been a priority. And I think that once we prioritize the needs of Black women and we meet the needs of Black women, I think everybody's care is going to be better. So with that, I think I'm a few minutes over, but thank you so much. And I'm happy to have a further discussion about this in our other group, the breakout group.
Wow. Thank you, Dr. Felder, for that rich, enriching, eye-opening presentation. It was extremely relatable. It was, the data was just so powerful to see. I think it also just sort of solidifies, sometimes you wonder if what you're experiencing really has this impact, and to see it on paper, to see that this is actually, there is a connection there, is, it's affirming. Also, it's mixed emotions, but it's really timely. Like someone said, Valencia Robinson said, it's so powerful, and you're getting a lot of feedback in the comments. So thank you for that. And I look forward to us, later on, once we come back from our breakout sessions, we will, audience members will have a chance to ask Dr. Felder questions. So if you do have questions, please start to add them into the chat, especially if you want to make sure that you don't forget your train of thought. Okay, so now I am going to share my screen again just to make sure that we continue on our process. Okay, we are going to go into the breakout rooms at this point. I'm going to share, so the breakout rooms, as I mentioned, I'm just going to go back to the beginning slide just to for you guys to understand how it's going to work in terms of the time. It will be, so since we're starting a little bit later, we're starting at 9:50, 9:53, and it runs for about 30 minutes. So we will finish around 10:23. Well, 10:30, actually. We'll go until 10:30 for it. For those who are going to be leading the breakout session and for those who are the note takers. So thank you. Again, when we get into the breakout rooms, if our patient experts, please feel free to start the conversation and share, introduce yourself, and also maybe have other people introduce themselves so that you know where they're from very quickly, and then explain about your experiences, maybe some of the conversation from Dr. Felder's presentation, hear what other people have to say, and also share your experiences as it relates to that. We will reconvene here at 10:30 to go over, to reconnect the data and the real stories. So I'm going to stop the share. Please be patient with us as we, Tonya from Tigerlily Foundation is going to put us into our breakout rooms. Those who are not in the breakout rooms, we're going to have our own conversation in here. So just, hold tight for a little bit. I'm also just letting you know, I'm putting now.
Thank you. This was such a just amazing opportunity to be vulnerable and to share my experience. And the main points that I shared was, you know, my personal experience, but also how to really reinforce trust between particularly the African American community and the medical professionals. And that is by being accurate and giving the most accurate information about your diagnosis as possible when it comes to the patient, and also making sure that they know upfront all of the genetic testing, clinical trials, and things that are available to them. I shared that I just was advised yesterday, after being a survivor for 6 years, that there has been a change in my diagnosis simply because, and how that created a true breakdown and upset within me, because they prescribed me tamoxifen for 5 years, which I discontinued after 3 months, which I was told just yesterday, I had this appointment yesterday, that it would have actually not been fruitful for me to take the tamoxifen at all. But at what point would that information had been disclosed, paying $1,400 a month for tamoxifen and Lexapro for 5 years? So thankfully, guided by spirit, I just, you know, advocated for myself and said, if this is not an option that's available. So really discussing what advocacy looks like, again, asking questions, addressing any inaccuracies, and just making sure that you're getting the best possible care, because I was able to say, okay, help me to understand what these changes are, help me to understand why I need to do this, and being able to be in a position to be like, you know what, I do or do not have to do this, and how can we move forward? And so that's really what we discussed, is how to really strengthen that relationship with accuracy and not treating everyone with blanket treatment, because obviously that is not the way to go, because some things really truly are not necessary. So it's important to position ourselves as advocates, but it's important for medical professionals to have absolute consideration, compassion, empathy, and no biases when it comes to age and race. Thank you.
Thank you, Patricia, and thank you all of your group members for sharing that. It sounds like it was a really enriching conversation, really powerful, that you guys definitely discussed a lot. And thank you for sharing about, you know, what takeaways we can do from this moving forward. So thank you, Patricia. We're going to hear from Breakout Room number 2, the lead from that.
So in our breakout room, we discuss being a self-advocate for yourself when you're going into appointments, not being afraid to ask questions. And if you disagree with what your provider is advising you of, or the information that he's given, not being afraid to get a second opinion, and for your physician not being, offering to advising you to get a second opinion if you're not comfortable with the information being provided. In addition to, with certain diagnoses, for example, myself, I'm a triple negative. I'm triple negative, so advising the patients of all that comes along with that. Myself personally, I was aware because I had done a ton of research myself. So I was aware of a lot of things that wasn't brought to my attention, such as possible side effects, reoccurrences, and things of that nature. But being upfront and providing all of that information to the patients, treating each individual case differently, because someone with triple negative breast cancer, you know, you can't give me the by the book information for someone that is not a triple negative breast cancer patient. We also spoke about clinical trials, how there is a lack of clinical trials with African American women. I was given the opportunity to participate in a clinical trial, but I do believe that there needs to be a better method of selecting the candidates instead of being selected by a random pool of numbers. I'm not sure exactly how they do it, but specifically targeting African American women to be allowed to participate in these clinical trials. I think that's extremely important. And we also spoke about generational pain and fear, discussing your family history, knowing your family history, because most times women are not advised to get a mammogram until they're 40 years old. But if you have a family history of breast cancer, it's extremely important that you get your mammograms before the age of 40, and also the importance of getting the genetic testing done as well. I think that's something that's not offered or touched upon as often as it should be, especially with women that have a history of breast cancer. Genetic testing is something that should be offered, whether you are 25 or 40. If there's a family history, this is something that needs to be offered, I believe. Versus saying, no, you're too young, you can't have breast cancer. I've seen this happen with my niece. She told them that she had a family history of breast cancer. She's 25, and they told her that she doesn't need to have it done yet because she's too young. But you have a strong family history of breast cancer, so why wouldn't you recommend that she get the genetic testing done? So that was my take on our breakout session, and it was just being aware, being a self-advocate for yourself, asking questions, getting a second opinion if you're unsure or uncomfortable with what your medical team is telling you, staying on top of your family history, knowing your family history, and just advocating overall.
Thank you, Tonya. Thank you. Yeah. That was really, yes, very powerful. And you all really went in and gave a lot of really great, helpful solutions and tips on what to do and what can be done from this. So thank you. We're going to hear from group number 3.
Yes, that's my group. I said this when I walked into the room, and after introducing myself and learning who was in the room with me, that God don't make no mistakes. So he's very intentional. We talked about genetics, and when I said something about not being treated by the book, I wanted to expand on that. And basically, I posed the question, if we know that there are disparities within Black health, but more specifically breast cancer, because that's what we're here talking about today, we know there are disparities with Black women and the mortality rate is higher. Why are we treating by the book? If we have the genetic testing in place, I did a comparison trying to understand why biologically Black women may have the same, carry the same gene mutation as white women, but we're dying at a higher rate. Is anybody studying us more, to find out what's causing our death rate to be higher? And I was in the room with a geneticist and she broke it down for me. And I so appreciated her. I was also in the room with a nurse and I shared a story of how this just happened yesterday. A neighbor of mine, 49-year-old Black woman, never had a mammogram, stage one breast cancer. Nurse, she's a nurse, never had a mammogram, 49 years old Black woman. And I could not understand for the life of me, how does that happen? How does that happen? And I've always thought, because remember, I started my journey in January. So I'm learning from everyone else along with my journey. And the fact that I do take the initiative because I'm inquisitive, AKA nosy. I go and I read information for myself because I want to know what's going on with me and how can I care for myself. And I didn't realize that I faced disparities. I really didn't realize that. I didn't realize I was in that group. And the reason why I didn't realize that is because I have had health insurance for the past 27 years plus, because my mom always kept us on health insurance. I always thought that I was being exposed to the best care, or at least because I was going to the doctor. But oh no, there are a lot of disparities. And I even talked about the fact that I didn't have genetic counseling until a year later after being genetically tested. Didn't know about genetic testing besides Angela Jolie with the BRCA gene years ago, but I didn't know about genetic testing, but how I got the information from my Black gynecologist and how I got the information about someone broke down my genetic testing results. That was done by a Black nurse practitioner. How my breast specialist, who is a white woman, maximized her clinician, which was the nurse practitioner, to talk to me, because I believe she knew culturally, she knew how to break it down. They got together. So there was representation there for me in my breast specialist office for somebody that looks like me to tell me, hey, girlfriend, even if she would have said, darling, you know, whatever, she still broke it down to where I can understand it and receive it in a way to where I would be take action. And then my breast specialist came in and broke it down some more. So we talked about all of that. And the takeaway for me is they are looking into looking at the different genes. I heard it's over 20,000 genes we have. I didn't know that either. I think I got that number right, 20,000. But we have a lot of genes, and they are looking at all of the genes and then all the different populations that the genes are coming from to kind of get more understanding why those mortality rates are higher. I'm hoping that they study us like they did the Ashkenazi Jewish women. I'm hoping that they take Black American women and say, okay, this is the group we're going to study. We're going to figure this out, because I was diagnosed with one of the more aggressive triple negative, breast cancer. So that was pretty much the takeaway. And then there were some other things going on, but I don't want to talk about it because we're going to connect after. But it was really a really awesome conversation. And I'm so grateful for this platform to help others, but it's also helping me understand what I need to do, but the responsibility on me. So thank you.
God is good all the time. All the time. God is good. Yes. So thankful for you. Thank you, Aliya, for sharing that. And yes, for the movement that happened in that group. Joy, last but not least, group number 4.
No, thank you. Sorry, I had some technical difficulties in my group, but on my end, so sorry about that, ladies. But there was a few things that we talked about. First kind of talked about around the family history and just really kind of making sure that is kind of connecting the dots for people. And when you're getting BRCA to screening. So what I mean by that, once you have breast cancer and you get the genetic testing, that's one thing. But you kind of know, hey, yes, I know for sure I am BRCA2 positive or have the mutation. And so now I know where it kind of came from. But I think that when I say connecting the dots is, how do you connect the dots with your family members who also need to get screened, and so that they understand why they need to get screened. And when you have Angelina Jolie or people like that who are kind of going out and having these double mastectomies preemptively and things of that nature, that's kind of scary to people. If they find out if they have BRCA, do I need to go preemptively get this, double mastectomy? So I think it's really kind of connecting the dots of what does it mean to be, what information am I going to gain from knowing I'm BRCA2 positive? I mean, I have the BRCA mutation, and what types of pre-screenings or what types of other things that are life decisions that I may need to take in consideration, now that I know, and what conversations do I now need to have with my children as well, and so I think it's how do you specifically connect the dots in a way that people can connect to it and it's not too scary of this whole Angelina Jolie kind of mentality. And the second thing I kind of talked to them about was around kind of that superwoman schema that Dr. Felder talked about as well. For me, I've been battling breast cancer for 12 years, and I've always worked. I never really took time off. I've never, I worked through my chemo, all those types, and radiations were made around my work schedule. I even took the bar. I was in law school part-time for a lot. And so I even took the bar while I was still undergoing chemo. And so I said all that because it's like someone needed to shake me and be like, hey, you need to take some time off or take a break or, take a breath. And when I was first diagnosed, my surgeon was a Black surgeon, and she was able to do that. She was able to kind of shake me and say, hey, you have to take some things off your plate in order for you to go through this treatment. You can't work full time, go to law school part time, and fight breast cancer. you just can't do it all at the same time. and so she was able to do that. But so my discussion with them is more so, I'm not sure if I had a white male doctor, if he would be able to shake me the way that my Black female doctor was able to shake me and say, hey, you need to let something go right now. And I don't know what that connection is. I'm not sure how a white male doctor could connect with me in order for me to shake me and say, you need to let something go, that you can't do it. Like, you're making it seem like you can't do it. So I just think, I'm not sure how to make those connections, but I did kind of just realize, just kind of took that into consideration. And then they also asked me around some things around my support system and also clinical trials. I did tell them I had been offered a kind of a clinical trial when my breast cancer had changed, went from hormone positive, and then they had found some triple negative cells, and we kind of talked through it. And so they did present that, and they presented some clinical trial options, but they presented it to me in a way that wasn't, a last resort. Like, because when I think of a clinical trial, sometimes people think of last resort, and that is some of the things that I had to kind of work around. And I think that as a Black woman or even other women, people think of clinical trials as a last resort. And I think it's similar to that whole family history discussion is, how do you, talk to women and to Black women around the clinical trials that they can kind of resonate with and kind of connect those dots. And I do think my oncologist did a great job with that, but I don't think that is I don't think that's the standard when people are being offered clinical trials. And then lastly, but not is around the support system. So obviously my family and friends have been a really great support system. But one of the things, especially in a metastatic breast cancer space, is, support groups are not my forte. I like other types of experiences with people with cancer, and like would it be like retreats or forums like that we're in right now, where I am able to learn about how other people are being treated and how I may or may not be treated. And I'll give you one example is I met a woman who said she didn't have breast cancer initially, but she had a family history of breast cancer. She didn't have the BRCA2 1 or 2 gene, but she was placed into a high risk program with her doctor. And I'm like, I didn't even know that there is a way that you can be classified as a high risk, individual for breast cancer, even if you didn't have like a specific, family history of BRCA 1 or 2 or things of that nature. And I don't think a lot of other women, especially Black women, are not offered those types of programs for high risk. And that's not her fault. I just feel like it is not being presented to situations. And having these types of forums and discussions are a way for you to kind of learn about those different types of disparities. Sorry, I didn't mean to go on a whole tangent like that, guys, but hopefully that was helpful. It's been really helpful for me. And so I wanted to thank the ladies in my breakout group as well.
That was extremely helpful. Thank you, Joy, for saying all of that, compacting it into such a short period of time. Well done, because there's so much that we've, are learning. I know that we are getting closer to the end of our time, and I want to be respectful of everyone's time. Oh, let me see if I can stop. Yeah, be respectful of everyone's time. So I just wanted to see if Dr. Felder, if you have any, comments based off of what you're just hearing, any last minute sort of takeaways before I just sort of share everyone's information as well.
I just want to start with saying thank you for allowing me to be a part of this conversation. I think that all the conversation that has come out today, to me, connected so nicely to the previous conversation that we all had as a group. And I think the biggest takeaway for me is being engaged in this conversation and hearing the personal experiences of each of you as patient experts. I think just drives home to me the need for your voices to be in research and in healthcare. I think one of the participants in our in our larger group Timmy shared about how she gained more information from actually connecting with Patricia on social media than she did from her providers. And I think that the experiences that patient experts share fill in a lot of gaps that providers don't share. And I don't know if it's always intentional that they don't share it, or it's really just not, from their perspective, they're not thinking about that because they're thinking so much about the cancer and not so much about you as a person, and that emotional and psychosocial side of who you are. So, so again, I think for me, I think we just have to keep driving home that, you know, your voices are needed, necessary, and can improve the quality of life of other women, particularly Black women who are dealing with breast cancer.
Thank you for sharing that, your takeaways. I just wanted to thank everyone for their time, for their coming with a listening ear. Thank you to the women who have shared their stories, who are also learning and empowering one another. I wanted to share, ask you to please follow our panelists on social media. Please take a screenshot of this if you don't have it. If there are other ways that you would like to connect with them, and panelists, if you would like to share your email address or whatever other ways, please feel free to add that in the chat so that you know, you can connect with those that were in your group. I just wanted to also just give you guys a little quickly our next, let me pause this. Our next conversation, we're going to continue this conversation because it's so powerful that it can't just be 1 month. We need to keep it going. So next month, we're going to continue this same conversation from in a different perspective. And we're having, our conversations are going to be November 13th and the 20th. Sean Johnson, who is he's a medical student at Harvard Medical School, will be sharing, will be our keynote speaker. So I invite you to join. This is one of his, this is from Tigerlily, our website. He was recently one of the people from our My Life, My Legacy. So please look for that on Facebook and to learn more about his story. And lastly, I think that is all that I have. Let me just make sure. I think that's the final slide. Yes, it is the final slide. So let me just stop my share. Thank you, ladies and gentlemen, for your participation. Thank you for sharing. I want just to reiterate how important it is for us to have these conversations. Some of the women that are in here that joined today was because of learning from breast cancer survivors that they looked up on the internet. That is how they found this conversation. So your voice sharing, it matters, and it's really making a difference in so many people's lives. So thank you for that. Thank you for holding space. Thank you for being a part of the solution.